Thank you very much for having us to speak today. It's a great pleasure to be here on behalf of my team. My name's Sarah. I'm a consultant in maternal and fetal medicine, and I work at the University of Edinburgh. And we were interested in antenatal corticosteroids, or ACS, given to twins and what the risk is with neonatal respiratory morbidity around the time of term birth. So just a little bit of background to the topic. We know that steroids work for lung maturation in preterm babies. They've been used for a long time, since they were discovered in the 70s by Liggins here. And it's now standard practice to give any baby at risk of preterm birth steroids prior to 34 weeks. And they're listed now in the WHO list of essential medications. But what we don't know is the late preterm period, so the 35 to 37 weeks. And this is when a lot of preterm births occur. This trial was done in singletons specifically and showed that if singletons at 35 to 37 weeks have steroids, it does reduce the risk of respiratory support in the babies. But we were interested specifically in twins because there's not a lot of evidence for the use in twins. And the research that is done is often just extrapolated from singletons. And most twins are born in this late preterm period because that's when we say they should be born to reduce the risk of stillbirth. And there's a huge variation in practice across the world. Some clinicians give steroids in this age group and some do not. So there is clinical equipoise. And attempts had failed to do an RCT. So I was very keen to see if we'd be able to do a network study to answer this question. So our research question is, does ACS given to twins prior to birth between 35 to 39 weeks reduce the risk of neonatal respiratory morbidity? And our target cohort was women with a twin pregnancy exposed to steroids. Comparator was those not exposed, and then the outcome was neonatal respiratory morbidity. So the next couple of slides just show how we created our cohort definitions in Atlas. First thing was to create a twin birth concept set, which included all of these at the bottom, and that was relatively straightforward to do. We then had an inclusion criteria of corticosteroids, and we were only interested in the injectable corticosteroids, so we had betamethasone and dexamethasone. We weren't interested in mothers who had had inhaled steroids for other reasons. And then we also wanted to specify the gestational age period because we know that preterm babies will all have had steroids. So we're interested specifically in this 35 to 39 week category. So again, this was an inclusion criteria in our cohort. And when we looked at this, we could see that actually if you reached every week of gestation, you got a code for this. So we wanted to make sure that we had the one related specifically to the birth. And so we had to put these conditions in 0 days before, 0 days after the start date, which was the twin birth. Our comparator cohort was relatively straightforward, exactly the same, except exactly 0 with antenatal corticosteroid exposure. It was a bit more tricky to define our neonatal respiratory morbidity concept set, and I very much did this with Taylor in our group, who's a neonatologist. And what we wanted to capture was respiratory distress and transient tachypnea. So there were lots of things included within this. And then similar to Liz, we don't have the mother-baby linkage yet, but Ben very kindly ran what we had in the Johns Hopkins database just to get the numbers in each of the cohorts. So the twin babies is all twins within the cohort. We're not able to specify with them whether they were exposed to ACS or not, but the mothers, we can see who's been exposed to ACS and who's not been exposed. So you can see the number counts there for each of the groups. In terms of the demographics, pretty similar actually between the two groups, which is what we would expect in terms of age and race. And then running our neonatal respiratory morbidity in all the twins. So again, this is not specified whether they've been exposed to ACS or not, because we don't yet have that linkage. So you can see that almost 50% of the twins did have respiratory distress syndrome classified, and this is what we would expect given that a lot of twins are born preterm. We are also very interested in some other neonatal outcomes because these are specifically related to steroid use. So we know that neonatal hypoglycemia is increased in the steroid group. So we wanted to see if we were getting good counts of that, which we are. And then the other three are potential side effects. Intraventricular hemorrhage, we think, gets better with steroids, and we have counts of that. Sepsis and neck potentially get worse with steroids. So they are very important secondary neonatal outcomes for us to look at. So the next steps here, again, similar to Liz, the Ben tells me the linked mother and baby data is available now within Johns Hopkins. So the next thing would be to look at the counts of RDS in both the target and the comparator cohorts. It would be great to get some data partners to run the characterization on what we've done so far. But our ultimate aim, similar to the other studies, is to do a population level effect estimation and look at ACS exposed versus non-exposed and see the difference in neonatal respiratory morbidity. And the last thing that we'd like to do, which we'll probably need to do a characterization first to look at this, is to try to investigate the timing of the steroid administration. So we know that a partial course is probably helpful. A full course is obviously very helpful, but the timing of that does matter, and it's of most use within the 7 days prior to birth. So that would also be a very interesting thing for us to look at. So I just want to thank my team members for helping me with the presentation, and of course the MHF faculty, and I've really enjoyed the fellowship. Thank you so much for having me.